So polyps, the discussion is pretty quick here. You can see there, that's the initial film on the HSG. Something's going on there. You can see that shadowing. That's why it's very important, because it can be very subtle. Saline infusion sonogram, office hysteroscopy, all techniques that you could use to diagnose polyps. And that's the office hysteroscopy. I like office hysteroscopy rather than saline infusion sonograms because the patients appreciate it better. This speaks a lot more than a lot of fuzz with the saline infusion sonogram, so I do that very liberally and it's very tolerable. To remove them or not, I think the literature is very soft on this. There's no right way, wrong way. I have some of my partners do micropolyps. They're big on doing the micropolyps, and they do the morcellation technique, and they just like lawn mower it there. I don't know if that makes a difference, but certainly we tend to, clinically at SRM, tend to, if we see it, we take it out, if they're especially doing IVF. But the literature is very soft on it. You can see there's really not a lot of big difference, but it's hard to sit on a polyp and put an embryo in there when the procedure itself is so simple. And you could do this actually in the office. And sorry, Hologic, this is TrueClear, but they're both equal in terms of performance. You can see it's very quick, and this takes literally 30 seconds to do. So we tend to remove polyps whenever we see them, regardless of size, regardless of location. We just remove them because it's so easy and quick to do. Oops, sorry. Okay, so just another picture. There's, again, a lot going on there. Uterus, there could be some polyps in there. You got this going on. That's probably a hydro. The left looks open. There could be some loculations there. Who knows? Thinking endometriosis, of course, right? So you got a lot going on. When you have blocked tubes, you always have to think of endometriosis. Got to do the natural thing, the history. Quality of life is always my key word. Is it affecting your quality of life? Obviously, that's very subjective, but it's what I use in terms of deciding whether or not to operate on a woman who's desirous, or at least in the future desirous of getting pregnant. And obviously, the classic ground glass appearance of an endometrioma is concerning. And soft criteria, ovarian reserve testing, less than 40, that's when I would be comfortable with operating. But you have to have that preoperative discussion about the effect of operating on that woman's AMH and ovarian reserve. Too many times I've seen non-REI. That's why I continue to operate, and a lot of my colleagues are not operating that much, but that's why I continue to operate, is that there's been literally ignorance of the normal ovarian stroma when that cyst is removed. They burn the shit out of it. I actually like bleeding on a cystectomy resection because that actually reassures me that stroma is and if it's bleeding too much, there's control. You just control at the vascular pedicles. You take that clamp and you put it at the hilum, you put it at the IP, and the bleeding will stop. It will stop. And if if it's still bleeding, then I put a suture. So again, encouraging people to use non-energy techniques to remove a cyst. I hate using a robot, but I do on endometriosis cases because the visualization is a lot better, and I'm able to use CO2 laser and all that kind of fancy non-destructive energy if I have to use an energy. I definitely, every time the nurse asks me to use should I hook up the unipolar? And I'm like, no, don't even put that thing on. So I never use the unipolar for reproductive surgery. Okay, so adhesions. Intrauterine adhesions is a very classic demonstration of adhesions. This is fairly obvious. I think most of us would diagnose adhesions, but when I see referrals, I usually do an office hysteroscopy to kind of gauge it, and then a lot of people ask my regimen in terms of postoperative adjuvant therapy, in terms of managing intrauterine adhesions, and you guys can do this as a generalist. can do this. I do place the intrauterine balloon under ultrasound guidance. Too many times you try to put it in blindly, it's in the lower uterine segment, you have to pull it out at post-op in the PACU. We've all done that. I strongly encourage ultrasound guidance, high dose estrogen management. The regimen doesn't matter, estrase, Premarin, whatever. And I do it for at least 2 to 3 weeks. And then I repeat the office hysteroscopy while they're on the estrogen. You don't need to give them a withdrawal bleed. You can go in, you can see if there's adhesions, and then I counsel them about, pretty much the good chance that I'm going to be able to restore their normal uterine cavity. But you have to counsel them that their miscarriage rates are still going to be high and their chance of getting pregnant are going to be lower, regardless of how great a surgeon that you think you are. So that's probably the most important in terms of expectations. Steve talked about this in terms of management of hydros. Pretty much in the IVF world, ART world, we remove these tubes because the literature is actually very, very solid on this, and there's actually a committee opinion on it. Reduction of chance of getting pregnant by 50%, miscarriage rates actually a lot higher. So anytime someone's doing ART, we remove them, we clip them, whatever works. Every once in a while, my fellow gets absolutely excited when I see a patient and I'm able to do a salpingostomy, neosalpingostomy, and this is just my technique in terms of how I do it. I use the robotic platform. I have done it straight stick, and it's just super, super hard, and I use laser technique, and I make a cruciate incision here. This is the end of the tube, and I make a cruciate incision, and then this is my laser here. I don't know if you've ever used it, probably have, but that's my main form. Because I've used unipolar, the needle tip cautery, but there's obviously too much collateral damage, and then I put energy on the back side of these to kind of curl them open. The success rate really isn't that great, and I would promote IVF on these, but there's an occasional patient where they're just not into the IVF situation, and so I like to be that provider that's able to give them options. All right, thank you for inviting me to the sun.